Well, since we're waiting, are you seeing a lot of critical limb ischemia, Dr. Alper?
Oh, absolutely. And, it's only increasing. I mean, part of the problem is the increased incidence of diabetes in general, but as we all know, these are silent diseases. And so by the time patients actually seek care or are referred, we're looking at stage 3, stage 4, intervention. And unfortunately, many of our colleagues are still not really aware of what to look for or are just not doing what needs to be done to look at it and to get that early intervention. And
Mm-hmm.
ADA comes out with the statistic that 85% of amputations are preventable with early intervention. And so it's really getting the eyes on it as early as possible.
What percentage of your patients with CLI have wound problems or present with wound problems?
Well, in the world of podiatry, I would say it's a high percentage just because that's what brings them to me. If somebody is simply having like dusky toes or, changes in the legs, I mean, that's not something that necessarily would come to me. That might either be through the PCP office or if they have a previous history of vascular conditions. It's when somebody has a non-healing wound. Doctor, I noticed some blood on my sock, and I looked on the bottom of my foot, and I got a hole there. That's when you really find yourself going into the podiatrist. And then in my assessment, I see, either PAD or more advanced in a CLTI situation.
Well, that's kind of good and interesting because for some reason the subpopulation who present with wound problems seem to be respond best to these stem cells, not only in our study, but in other studies as well.
Mhm.
Huh.
I was wondering if that phenotype of the wound may be different to some of the other types. I had assumed it simply the the worst grade, but there may be a specific phenotype that presents more with a subpopulation that presents more with wounds as opposed to other things.
Well, it's certainly possible. I mean, the reality is you don't have to have a wound, of course, to get to the level of a CLTI situation. There has to be some form of trauma, whether it's chronic irritation, whether it's, loading improper footwear, I mean, these types of things. So you could be at an earlier stage of just a PAD patient that develops a non-healing wound, a DFU wound. And so that's the type of patient that I would see coming in. Obviously, I make the referral for revascularization,
Mm-hmm.
and this is where we get into other conversations. Is the patient getting an angiogram to even see if revascularization is possible, or are they just going for the amputation because it's the easy thing to do, which
Mhm.
drives me crazy, but that's another conversation for another time.
Sure.
Um, but your point, Dr. Henderson, is that you can certainly have the wounds at an earlier stage that we need to deal with, as opposed to somebody who's full CLI that just, for whatever reason, hasn't developed a wound.
Mhm. If I could just say, welcome to all participants. Thank you for joining us this morning. My name's Thomas Smink, President and CEO of Hemostemix, and it's a real pleasure to introduce Dr. Fraser Henderson to you, who I will turn this mic over to now. Dr. Henderson?
Hey, good morning. Hi, I'm a practicing neurosurgeon. I'm actually on trauma call today. So if I get beeped out, you'll know what happened. Um, and I'm delighted to talk to you about the angiogenic cell precursors. Next slide, please. So we're talking about a hematopoietic stem cell that's in the peripheral blood, and it's collected from a simple blood draw in the clinic. And there's a specific layer of these cells that are then differentiated to become the synergetic cell population, which then is exposed to various factors, one of which will create the angiogenic cell precursor cell type. It can also create neural cell precursors and other things, but we're going to talk about the ACP. Next slide. There's been some excellent preclinical work next. But I'd like to first talk about the safety of the cells. I already said it's obtained by a simple blood draw, so there's no painful bone marrow harvest, no complications associated there. And it's not a fetal tissue, which has ethical concerns. There's no risk of any kind of virus or pathogen. And it's not a pluripotential cell that has the significant risk of neoplasia. And perhaps most importantly, because it's an autologous cell, there's no risk of a condition like Jakob-Creutzfeldt, which is a transmissible spongiform encephalopathy like mad cow disease. That's extremely difficult to test for, very expensive, and clinically doesn't show up for 5 or 10 years. But when it does, it causes a rapid death over a course of 6 to 12 months. Now, the first time someone's treated with an allogeneic cell, who then develops Jakob-Creutzfeldt disease, will be the last time they use allogeneic cells in the market. So this is an autologous cell, very safe. Next. And it's been used now in over 500 patients, 300 of whom are in published studies, and there have been no complications associated with the cell itself. There was an MI that I'll talk about later. Next. There's also been 2 manuscripts discussing the biomolecular attributes of the angiogenic cell precursors. Next. So we're going to talk first about cardiac disease, ischemic and non-ischemic cardiomyopathy. And we're talking about many, several million patients in the United States. And then we're going to talk about, more pertinent today, the critical limb ischemia or chronic limb-threatening ischemia, the prevalence in the United States of which is easily 2 million, maybe substantially more. And I'll touch on inflammatory vascular pain, which I thought might be interesting, especially to Dr. Alper. Next. So how did Aram's study of 41 patients with ischemic cardiomyopathy, the most common type of heart failure, and 21 patients with dilated non-ischemic cardiomyopathy, we see that more in children and other unusual conditions that predisposes to the need for heart transplant. And at 6 months, we saw a significant improvement in the New York Health Association functional class, improvement by 126 meters of the 6-minute walk tests, and a 5% improvement in the left ventricular ejection fraction in both groups. So these patients, the normal ejection fraction, of course, is about 60%. These patients had an average ejection fraction of 30%. So an improvement of 5% in ejection fraction is about a 16% improvement in cardiac function. Next slide. And in Chithurophan's study of 106 subjects, there was a highly significant improvement in the Canadian cardiovascular score and the NYHA score, and again an improvement of about 5% in the left ventricular ejection fraction. Next. And in Damras's study of 24 subjects with intractable angina, again we saw a highly significant improvement in Canadian cardiovascular angina score, Canadian Cardiovascular Society angina score, a 6-minute walk test, And the perfusion defects decreased from 38% to 21% at 6 months. Next. And more recently, our study of 53 patients with both ischemic cardiomyopathy and dilated cardiomyopathy, next, showed a 5% improvement at 4 months in all patients, and the ejection fraction representing, shown in blue, an increased cardiac function of 16%. And at 12 months, this increased to an increase in cardiac function to almost 27%. When we broke it down to ischemic heart failure, it's about a 24% improvement in cardiac function at 12 months. But in the non-ischemic heart failure, the dilated cardiomyopathy, which is characterized by scarring and of the heart, there was a 47% increase in cardiac function. Next slide. So when we looked at the quartiles on the far left, that's less than a 20% ejection fraction, so 1/3 of normal. And next to it, the 20 to 29% ejection fraction. So these are the two groups that often die from sudden onset of VTAC, but they're the ones that showed the most improvement overall from the stem cells. Next. And there's the quality of life studies were not well done, but there was a comparable improvement in quality of life. And I'll mention here that one patient had died during a day after the transcatheter implantation of the cells. He had had an unwitnessed silent MI 2 weeks before the transplantation. He should not have been in the study. 2 patients had tachyarrhythmias just treated with cardioversion. Next slide. So we're going to be pursuing, focusing on the idiopathic dilated cardiomyopathy in further studies next. But today we're going to focus a bit more on critical limb ischemia or chronic limb-threatening ischemia. And we're talking about 200 million people worldwide with peripheral arterial disease and 12 to 20 million Americans with a CLI prevalence in the United States of about 2 million. And some people say more than that. Dr. Alper probably has the best idea there, but there's a 6-month amputation rate of 10 to 40%, 50% for diabetics. And after a major amputation, the 1-year mortality is 40%, and that's for US Medicare statistics. We're spending a fortune taking care of these patients, especially on the diabetic patients, $120,000 per year for each diabetic patient with CLI, $70,000 if they don't have diabetes. Next. So in Szebo's phase 2 open label randomized clinical study of 20 no option critical limb ischemia patients, there were no side effects from the ACP01. At 3 months, they had improvement in the hemodynamic metrics, but at 2 years, they had improved pain, improved wound healing, walking ability, no deaths, and 3 amputations, as opposed to the control group where there are 2 deaths and 6 amputations. Okay, so this is a small and open label study. Next slide. And more recently, Zhang study done through Hemostemix. It was originally scheduled to have close to 100 patients, but the previous management stopped the study before they had completed the full enrollment. So we had to extract what data we could from the contracted study. But these were no option patients randomized 2 to 1 and receiving 30 direct injections of the ACP in and around the ischemic limbs, 1 cc per injection on the front and back of the legs. And next slide. So when we looked at the patients who presented with wounds, shown in blue, we saw a very significant improvement in wound healing in the patients treated with the ACP, as shown there in blue, compared to the controls, where there was no significant wound healing. Next slide. And at 12 months, there was a almost 5% amputation and death rate in the ACP group, a 25% amputation, 25% death rate in the placebo group, and the latter being comparable to US Medicare studies. Next. And some planned applications of the ACP. Next. We're going to resume the CLI phase 2 study, and hopefully double blinded and 100 patients, multi-centered. And I think Tom will mention that every center that participated in the earlier trial was very enthusiastic about the ACP and would like to participate in this trial. I think they're very encouraged by what they saw. We're also going to look at ACP for treating neurogenic pain, which we're talking about diabetes related pain and vasculopathy of the blood vessels, vasculitis. Next slide. And other causes of neuropathic pain, which cross over into the kinds of patients that you see, Dr. Alper, I think, and that probably many vascular surgeons see. Next slide. So how does ACP work? Well, fundamentally, and as in contradistinction to, say, bone marrow mesenchymal stem cells, the ACP programmed specifically to develop into blood vessels. They're epithelial tube cells, and they will form blood vessels. They're not programmed to form 20 different things like mesenchymal stem cells. They're like a bullet aimed from a rifle. So they form endothelial cells. They secrete vascular endothelial growth factor and angiogenin, and they vigorously promote angiogenesis and vasculogenesis. I'll discuss how they also release CXCL8, which is also known as interleukin 8. But next slide, please. So the ACP secrete vascular endothelial growth factor, which not only promotes angiogenesis, but also promotes the polarization of macrophages to the anti-inflammatory M2 phenotype. And as you know, with any injury, the macrophages and monocytes come in and cause a great deal of inflammation and destruction and pain. And this can help to clear a wound, or it can make it worse. Generally, we're trying to decrease inflammation. And the macrophages exist on a spectrum on the left, which are highly, and I'm not making a political commentary here, but highly inflammatory left M1 type monocyte, as opposed to the salutary immunomodulating M2 phenotype on the right that suppresses inflammation. So the vascular endothelial growth factor promotes the M2 phenotype. Next slide. And the ACP also express high levels of interleukin 8, and also known as CXC ligand 8, which has many salutary effects, one of which is that it is highly specific and chemotactic for endothelial cells like ACP, and it also mobilizes the peripheral CD34 cells. So within the systemic circulation are many CD34 cells, and the local concentration of interleukin-8 given out by the ACP attract these CD34 cells to come into the injured area. Next slide. And they've been discussed recently in the popular magazine literature, where this gentleman had a face and eye transplant, and his remarkable recovery was attributed to the presence of an enriched CD34 cell as histologic substrate, which they used. So the CD34 cells have, in addition to being essential to angiogenesis, they promote the organization of extracellular matrix, scaffolding, immunomodulation, regulation of other cell types. So this interleukin-8 attracts the CD34 cells, but next slide. The ACP, I should say, 1/3 of ACP is actually a CD34 cell. So not only do they attract further CD34, but we begin with ACP with a very high population of CD34 cells. Now, interleukin-8 also has the effect of upregulating nuclear factor kappa B through interaction with surface receptors, or next slide, through binding with surface receptors CXCR1 and CRCR2, which G protein coupled receptors that trigger phosphoinositol 3 kinase, that triggers IK kinase, that disinhibits nuclear factor kappa B, which is then, the dimer of which is then freed to translocate into the nucleus to bind to certain histones and express specific mRNAs to make proteins which are at once anti-apoptotic and which also have many other good effects. Next slide. And this we think this might be very important. This in the nervous system, this production of nuclear factor kappa B, we believe may be very important in preserving the GABA inhibitory interneurons to decrease neuropathic pain. Next slide. NK cells are really important. They're part of the innate lymphoid cell population. They're called natural killer cells. I think they're poorly named because they have a really, again, helpful immunomodulating character, and they're attracted to the site of injury by the presence, again, of the interleukin-8. These NK cells will help to mature monocytes and decrease the inflammatory aspects. They promote the M2 non-inflammatory monocyte. They cause lysis of the aggressive T cells, and they help to, they're very important in modulating the inflammation. So in wounds, drawing these natural killer cells, NK cells, into the wound is a very positive healing phenomenon. And in rodent studies of the heart, they found that the presence of the NK cells and the M2 inflammatory phenotype led to less scar tissue, shown in the two columns in the upper right. The M cell is less scar tissue there than the control. And conversely, there was increased muscle thickness and where there were more of the M2 cells compared to the controls. Next slide. Now, how do the cells get to the injured area, especially if you're putting them in systemically, or even locally? Cells will migrate. Well, injured tissue releases CXC ligand 12, also known as stromal cell-derived factor 1, which is a steady state chemokine, which has a very specific and powerful, it is a specific and powerful ligand for CXCR receptor 4. And CXCR4 receptors are present on ACP. So ACP released into the circulation will be attracted to higher concentrations of CXCL12, and this causes homing and migration and embedding of those cells into the tissue. So these receptors, however, are, whilst very prominent in ACP, are not on the mesenchymal stem cells, which after harvesting mesenchymal stem cells from the bone marrow, they undergo multiple divisions, and those CXCR4 receptors are thought to be lost with those multiple divisions. And I'll also mention, by the way, that only 1 in 10,000 bone marrow cells are angiogenic. So whilst the numbers of bone marrow-derived mesenchymal stem cells, whilst they are a huge number of cells that they usually obtain, only 1 in 10,000 have an angiogenic capabilities. The ACP, on the other hand, are all promote angiogenesis. So smaller numbers of cells are accomplish the same. Next slide, please.
Dr. Henderson, I'm sorry to interrupt, but just before people start going off to do cases, is it possible for someone to summarize the program for offering this therapy, at least in Florida? Thomas and I had spoken about that, and if someone could also outline the next potential study that obviously many of us hope to participate in, that would be great.
Sure.
Sure, that'd be no problem at all. What to do just a short, few-page summary of how the cells work and what we propose to do with the phase 2 study. Is that what you had in mind? Or Thomas, maybe you better answer that question.
Sure. Good morning. Yes, so in Florida, as of July 1, you have a new law, SB1768, which permits physicians to use non-FDA approved stem cells for the treatment of pain, as long as the physician stays in his area of practice. So ACP01, therefore, is available now as a product. This obviously requires informed consent. The ACP has to be produced in a FDA-regulated CGMP facility, which it is. And so for no option patients today, they have an option, and that option is ACP. The cost of that is currently borne by the patient. So the therapy itself is $37,000. Then on top of that is the physician expense and the clinic expense. We have a number of ways we have a payment plan for that. Of course, we have another initiative. Dr. Henderson kindly organized a 501c3 to accept donations to help the individuals who are economically disadvantaged to obtain a treatment. And we have a program that is focused on raising money to help individuals that way. In terms of our clinical trial program, we have, as Dr. Henderson mentioned, a clinical trial program that is focused on treating each of these indications in a phase 1, and we're doing that in the Bahamas, as the Bahamas has regulation which permits a company like Hemostemix to do that on a commercial basis. So for peripheral arterial disease, critical limb ischemia, ischemic cardiomyopathy, non-ischemic dilated cardiomyopathy, angina, vascular dementia, and pain, we have proposed to the FDA a basket protocol approach where we will study ACP in each of those conditions in an open label phase 1 manner that permits patients to be recruited and pay and be followed for 1 year. And that will fund our the phase 2 and ultimately the phase 3 trial. So the company has the financial structure with which to complete those studies. Any further questions, Dr. Shaw?
Can I just mention, by the way, that all of these studies will be IRB approved, of course.
Yes. Yes, of course. And we have now 4 of the protocols completed, 4 of the 7, and 4 which are now have been submitted for IRB approval.
Dr. Henderson, what is the actual procedure for administration of this? Is it simple injection? Is it does it need to be particularly localized as far as administration goes? How is this administered?
I think it's best administered locally through about 31 milliliter injections near and around the ischemic areas. The intraarterial injections don't seem to have had very good results. And the preponderance of data shows that the intramuscular injections seem to work the best. But there is the possibility, given the migratory characteristics of these cells and the fact that they're autologous, so that there's no major histocompatibility complex problems, no autoimmunity issues, that administered into the veins, these cells could also find themselves appropriately homing to areas of ischemia. So the literature shows the best results so far from intramuscular injection.
Okay. And this is done with local, this is done with just direct administration, this is sedation, this is...
the combination thereof, yeah.
Okay.
I can actually, sorry, this is Christina Giles. I'm up at Maine Health, but I was at UF when we ran this trial there before. And Nancy Haslin can probably tell you a little bit more detail, but we did the injections at one of the research buildings, and we had light sedation, and then the patients recovered over there. They've got it set up pretty well, and we used local anesthesia in the injections. It was a great process, so easy enough to do.
Okay,
we used ultrasound guidance, obviously.
Yeah. My other question, as far as the wound healing goes, Did this work with simple direct debridement of the wounds and allowed natural healing? Was skin grafts or skin substitutes involved? Is there any looking at it at all of how it helps a skin substitute application seal the wound?
It's only done in the context of natural wound healing without skin substitutes or anything like that.
Okay, thank you.
If you're proposing, phase 1 and 2 trials, back in the United States.
You finish? Oh, okay.
I had a question regarding, the previous trials, required a large amount of screening of patients who were enrolled in the trials for underlying cancers, so readouts, because of the angiogenesis activities of this agent, which could, make the cancer worse. So previously the company was helping and with, I believe, some of the offset of the cost of the extensive screenings that were required for to rule out cancer to determine candidates in these trials. Christina, could you comment on that?
That I don't actually recall exactly what the process was, but I don't remember it being that onerous.
Mhm.
It's been a long time.
Can the company
I
remind
would
us,
say-
how that cost was deferred? Was it just the patient's insurance soaking up the costs of extensive cancer screenings?
Yes, it was.
Candidates? It was, okay. So the company didn't offset any of that.
No.
Okay. If patients participate in a trial, a phase 2 trial, are they gonna be paying the $37,000 for the treatments, or is the company with those patients, seeking FDA approval, is the company gonna be paying for the medication?
Yes, so the correct, the latter. In the US, the patients in a phase 2 or 3 do not pay.
But just to be clear, when you're talking about this ability to offer it in Florida, you're not talking about a trial setting. I'm just clarifying for others on the call. This is an opportunity or an ability to access stem cell therapy outside of a trial setting if the patients can pay for it.
That's
and
correct.
The way that would work is we'd identify them, or whichever site would identify them. If they have the ability to pay for it, then we get their blood. That blood is processed and purified for these stem cells, sent back and then administered locally.
Yes, so the process, that's exactly right. The process is a blood draw on day 0 that is then shipped to Hemostemix, where it is essentially processed into ACP in the space of 5 days. On day 6, it goes through a quality control, quality assurance check while it's being shipped back to you, the treating physician, who is in a preset appointment on day 7 with the patient and injecting the cells into the affected limb. Typically, as Dr. Henderson mentioned, 31 cc injections into the gastrocnemius.
Any other comments or anything for us? We're gonna have to peel away in just a couple minutes.
No, that's obviously, if there are any additional questions, please feel free to reach out. We'd like to follow up with you individually, talk about this in terms of your practice, and work with you to help patients who really have no options, who now have an option under Florida's SB1768.
I will add, by the way, that even though the data from Florida won't be included in a phase 1 IND or phase 1 study, every procedure will be under the auspices of an IRB approved study. So this is this work will be, you can tell that to the patients that an IRB is overseeing the whole process, and will eventually use this real world data to help support our other studies.
That's great. Thank you so much.
Appreciate your time this morning.
Thank you very much for attending.
Okay.
Thank you all very much. Appreciate hearing it.
Pleasure to meet you all. Take care. Yeah.